Thank you. And thank you for having me here. Thank you for the moderators. Great work, Lee, Santiago, and congratulations to Lucas for the amazing work being the chair of this SVIN meeting. Great presentations and very well organized. This feels like a family reunion to me, as I'm here with these guys that I just mentioned, as well as with Joanna sitting in the back of the room. We've been working together, we started working together 12, 13 years ago as fellows, co-fellows, young attending, and obviously everybody has gone in different pathways, but it's great to see how everybody's doing so well. I'm going to show a case. This is a live case presentation. They gave me 9 minutes to speak. The entire case took 8 minutes, so I think we're good on time in there. First, just like Dr. Chowdhury showed, this is an example of a 3-year-old girl that had a sudden onset of left eye pain, proptosis, and this is her MRI showing the fluid level consistent with a lymphatic malformation. The reason why you have two different intensities is because there is a hemorrhagic component, and that's why she presented acutely with symptoms. You see the proptosis of the left eye. These are other views, and specifically looking at the contrast study in which there's no enhancement of the lesion, different from a venous malformation in which there will be enhancement. This is, you can do expert CT if you have a Philips, you can do DynaCTs with the Siemens machines to localize the lesion and make it a safer procedure to avoid hitting the eyeball. This specific girl had 2 stages of treatment, both with bleomycin. In this, we were mixing at that time bleomycin with contrast so that we could see it at the time we were injecting under fluoroscopy. In the first session, she received 5.7 milligrams of bleomycin, in the second one 2.5. We keep a log of the cumulative dose that these patients are receiving to diminish the risk of them developing total cumulative risk of pulmonary fibrosis. Nowadays, if we are dealing with a lymphatic malformation, we are not mixing it with contrast anymore. If we are inside the cyst and we get normal lymphatic fluid back, we know what we're dealing with. We just inject the bleomycin. That way you don't need to inject a large volume, and you diminish the risk of significant swelling, which could be a potential complication. This was her initial result after the first treatment. You don't see the proptosis, but the eye is looking downwards. Is because there was still a little component in the upper portion of the orbit. We treated her, that was the reason for the second stage, and this is her follow-up. So she did have great recovery, and this is another case very similar. Young boy that presented with proptosis, fluid level, direct puncture of the lesion, drainage of the lymphatic fluid before injecting the bleomycin. When I say 4.5 milligrams of bleomycin, we're talking about 3 milliliters. Actually 1.5 milliliter that we're injecting here. The mixture is 3 milligram per milliliter. And he had a second treatment with 3 milligrams, and this is the final result. I'm going to show the live case that I'm showing you specifically now. This is, you can see the hyper-intense characteristic, and then it does enhance with contrast. So this is really a venous malformation. And I'm showing this so that you can see the differences. And please criticize if you have any comments about the procedure. So we are accessing the lesion. You saw it was medial to the eyeball, so we are going to puncture medially to the eyeball directly. As I mentioned before, if there is a concern, especially if the lesion is small, definitely using a DynaCT or expert guide will help you. Like mentioned before, having an entire team of people is critical here. you can see I put the needle and we get blood back immediately. I'm gonna connect a line that has been primed with contrast. We knew that we were dealing with a venous malformation, so I wanna make sure that there's no escaping of the material that we're gonna inject either intracranially or that is not gonna be effective, because if it drains somewhere else, we're not gonna be able to treat the vascular anomaly. The line has been primed with contrast. Make sure you know the amount of contrast that you have in each of the lines, so measure them ahead of time. And I'll tell you why this is important at the time of treatment. We secure, make sure that we have stability of the line. Looking at the orbital lesion is easier to look at the lateral view than in the AP view to see where the contrast and or material that we're going to inject is going to. So we're aligning. We're going to get a blank mask so that on the roadmap we can inject. You see the needle in place. And now with the amount of contrast that we're going to inject is going to be very small, less than 0.1 cc's. It's just to make sure that we're intravascular and that there's no significant drainage anywhere else. So this full contrast is not diluted. Inject the small amount of contrast. You see there you're intravascular. It's not escaping anywhere else. To verify that you're intravascular, just disconnecting the syringe is enough. And you're going to see now when I disconnect the syringe and put the microcatheter in dependent position, and you're going to start seeing blood coming back the tubing. But by doing that, you know that you're intravascular, and by putting in dependent position, it's going to drain. By elevating it above the level of the heart, is going to start going in. Because we're working in a very small structure, very small space in these orbital lesions, we do not inject the bleomycin. We allow for gravitational forces to allow for the drip to go inside the cyst. So we put now you see there's another tube here filled with the bleomycin. And so we have pure bleomycin on the side. We're gonna connect to a side port that we connect here. And that's why I mentioned before the importance of knowing exactly how much of the dead space of the microcatheter that you're using to avoid injecting too much or too little, or infusing too much or too little. You saw that we did collect a little bit of the sample of the blood that was drained. We sent that for pathology. We're connecting now that other tubing. So, and this one was primed with bleomycin. So we're connecting at this site. You see it's back bleeding right now because it's a venous malformation. In a lymphatic, you would have just seen the lymphatic fluid draining, and or it could be hemorrhagic lymphatic fluid. Sometimes we have a mixed. If there are veins very close to the cyst, you can see the hemorrhagic component. And we always, if it is a lymphatic, we always drain it as much as we can. We don't aspirate, we just allow for drainage from gravity. Sometimes we push on the eye because that will push on the cyst as well to allow to make the emptying faster. And now that we have this line connected in the side port, the way that we're infusing is just by gravity. Since it is intravascular, just by putting it above the level of the lesion, it will go in. And we're doing it drop by drop. We know how much of the material we had in our syringe to begin with, so that we don't inject an excess of the sclerosing agent. We have been using bleomycin now, at least for the past 10 years, for orbital lesions because it causes less toxicity than others, let's say alcohol, or than even doxycycline and or STS. All of those cause a significant reaction that can cause significant swelling. Even with bleomycin, we have had cases in which patients have required lateral canthotomy to relieve some of the orbital pressure and prevent blindness. That's an emergency, and that's why it's important that you work together with an ophthalmology team, oculoplastic surgeon, ENT, so that they are in standby in case there's an emergency after the procedure. These are procedures that obviously we can help a lot of people. I don't know how many of you in the room do this type of cases, but it is gratifying to see how they improve kids or adults. So some of these adults have had these pathologies their entire lives, and without finding someone that can help them. And it's definitely very gratifying. So working together with pediatricians, dermatologists who see many of these lesions, pediatric hematologists who see many of these kids, ophthalmology, oculoplastic surgery, and ENT is critical. We finished the infusion of the sclerosing agent. Now we're gonna, for hemostasis, we're gonna put a little bit of Surgiflow. When I say a little bit, I mean like 0.1 milliliter. We don't wanna fill the space with this material and then have an increase in intraocular pressure. You see that we're injecting a little bit as we pull the needle out slowly, and that's it. That's the procedure. Thank you for your attention.